Namaskar. Good morning, good evening. Thanks for giving me the opportunity. Let's talk on FUE overharvesting donor area. Nothing to disclose. Overharvesting leads to various donor area aesthetic defects, secondary to faulty techniques of harvesting of hair follicles. This is mainly because of overshooting the safe excision limit, harvesting beyond the safe donor area limit, and the use of relatively large size of punch for harvesting, creating the more scalp show. When we look such donor area after harvesting, I feel we are burning the scalp of the patient, and I think it's a crime. When harvesting is done very closely, this leads to the necrosis of the donor area and then the secondary scarring. Similarly, overharvesting leading to significant scalp show. And when we do such overharvesting causing the necrosis, scalp show, I feel that we are destroying the house of someone, which is not good. So why the surgeon does overharvesting? If we pay attention to this, we can probably check over the overharvesting. The lack of knowledge, technical factors like safe donor area limit, safe excision density, and to meet with the unrealistic demand of the patient and to compensate surgeon's his own transaction and his poor results of hair transplant he has done before. So to compensate his transaction rate and poor result, he harvests more number of the graft crossing the safe excision limit. So various donor defects because of the overharvesting are like this was the case of FUT and FUE followed by donor effluvium. This is another case of overharvesting leading to significant effluvium and the scalp show. Another extraction from limited area using the large size of the punch. Similarly, hypopigmentation because of the large poor quality of the punch in beard as well as in the scalp. And this is poor growth despite of the overharvesting. So there are the two major mistakes or crime has been done in this case. Non-uniform extraction leading to poor donor appearance. So the surgeon has to make a balance between the donor area supply, recipient area demand, and the expectation of the patient. So how to avoid the overharvesting? The surgeon should know safe excision limit, residual density, donor area evaluation, hair mass concept, optimum punch size, and how to minimize the transactions and how to produce optimum results of the hair transplant, and we are going to talk on this also. So important factors which one should consider for harvesting means graft harvesting is safe excision density. This is the number of graft harvested without compromising the cosmetic density of the donor area. Most of the FUE experts recommend 10 to 15 grafts excision per square centimeter as a safe single pass density in a person with baseline average density of 65 to 75 grafts per square centimeter. But Dr. James Harris and even myself go for higher excision density means 20 to 25 grafts per square. A rough estimate is that 20 to 25% of existing donor density can be removed safely in one pass. Although this depends also on the availability of multifollicular unit, hair thickness, curl of the hair, and color contrast, and the size of the punch as well. The residual density is the donor density left after the graft excision. The donor density less than 30 or 40 grafts shows the visible thinning, which is significant. Let's take an example, like a donor area having the 70 grafts density. If we go for first pass excision of conservative like 10 to 15 grafts per square centimeter harvesting, then at the end you are left with 55 graft density. Again you go for second pass excision, again you harvest 10 to 15 grafts per square centimeter, and after second excision you are left with 40 grafts of the density donor. But if you again go for third pass excision, again you harvest 10 to 15 grafts per square centimeter, at the end your donor area will be left with 25 to 30 grafts per square centimeter only. So this will cause the significant donor area thinning and the scalp show, which will not be good. Although, as I have explained, this all depends on the other factors which I enumerated before. Now the coverage value. The scalp area covered by hair mass unit means we can calculate the hair density per square centimeter into thickness of hair. If we supposingly if someone donor area has got the 100 hair per square centimeter density and the hair thickness is 0.05 mm, his coverage value will be 5. And how it is important? If donor area has got the lower coverage value, this is going to limit the safe excision density. That's how it helps you. In extraction means excision of the graft, keeping coverage value in the mind. Now another concept what I feel is uncovered scalp area after the extraction. I call it USA. This is the total area covered by the hair minus area of hair extracted. I feel hair is a cylindrical structure, so length of hair shall also be considered, and not just considering the thickness. Length is equally important, and this will need more research to calculate precisely your USA. Let's take an example. This is the donor area. We go for 25% of excision, then this is the leftover donor area after the harvesting. This is a good area coverage by the existing hair. Another is if we go for 33% excision, again reasonable coverage we get. And if we go 50% excision, again you get reasonable coverage of the scalp by leftover hair 50%. But if we exceed more than 50%, like 66% you excise, then you are left with this donor area. Here is more is the scalp than the hair. So scalp visibility will be more, and there will be gross thinning which will not look good. Now the punch size also is important for scalp show or scalp visibility defect. If we use the larger punch, supposingly 1 mm punch, this is going to create 60% larger scar than the 8 mm punch. Let's see this example. This is the 0.9 mm punch scar, and these are the 1 mm punch scar. We can appreciate the difference between both. Another thing is, do not cross the safe donor area limit to meet with unrealistic demand of the patient and to cover the discrepancy of demand and supply. Rather, harvest from non-scalp donor area. This is how we should, the pattern of harvesting we should follow. Supposing if we are harvesting them too close, this is going to create the necrosis and the scarring and poor donor aesthetic. Similarly, if we are excising, harvesting them in a linear fashion, there are chances of a linear cut or the necrosis. So it is advisable to go for uniform excision harvesting of the graft, preferably 1 out of 4 or 1 out of 3. This will give you a good donor aesthetic. Now, few points for the second and third parts excision are following this concept is the orphan hair. Orphan hair is a single or isolated hair in a skin zone. If you excise it, you are going to leave an alopecia patch, and surgeon has got tendency to excise them. Similarly, shadow hair. Shadow hair is a hair covered by another hair, so it is preferable to excise a shadow hair, because once you have removed them, another hair which was sitting on the top will cover that area. Another few points are: do not excise all the members of the family, do not excise all multifollicular unit of the area, and it is advisable to engage epidermal blush rather than the exit angle of the hair. This is going to reduce the transection. And if you go for more transection, you do more transection, you are going to do more harvesting. Similarly, more damage of the graft during the removal of the graft means dissected graft will require more harvesting to compensate the damage. So it is preferable to remove the dissected graft by using the two forceps technique, and I keep them in the plasma. So if we follow all the basic concept of follicle harvesting, we can respect donor as well as the recipient area. Let's see few example of our. In this case, we extracted 3000 graft. After excision, you can hardly find the difference. Similarly, another case, again 3000 graft. Again we did 1800 graft in second sitting. Still the donor area is good. Third case, 3245 graft. After excision of the graft, you can't appreciate the graft has been taken out. Similarly, another case, 3135 grafts, again post excision donor area. Another case, 3000 graft, this is again the post excision donor area. Another case, 3336 graft, we did extraction in this, but still hardly you can appreciate the donor thinning. SMP is a good answer to camouflage the scar visibility. So the conclusion is, FUE is a surgical procedure. Graft excision shall be done by trained surgeon. It needs skill by learning, perfection by practice, and it is strongly advisable to learn under a senior FUE surgeon, best by doing the fellowship and attending the workshop, and watch FUE videos regularly, and start with smaller case. Thank you.